Okay, hello Pip. Thanks. You've come for your Mummy MOT today. How did you hear about Mummy MOT?
Through social media.
Okay, cool.
It's
Thank you.
pelvic health is something I follow, I look into, I like doing research in, and then obviously it crop up as the go-to.
Oh, thank you. And have you travelled far today? Where have you come from? Okay.
So a couple of hours on the train.
Okay, cool.
Nice, sit back, listen to a podcast, get a bit of work done.
Okay.
Lovely.
Oh well, thank you for coming that distance, and it's nice to kind of just escape, isn't it, and have a little bit of time for you. And so we're going to do a Mummy MOT. Was there anything in particular that you're concerned about, or you want me to pay a little bit more attention to during the Mummy MOT? Or?
No, I don't think so at this stage, so 18 months postnatally. When I was more sort of that 6-8 week mark, and I saw someone, my concern was I wanted to return to running, but I really wanted to do it in a sensible way, which is unheard of for me. But I thought that was the time to start being sensible. So at that point I was very much, what do I need to do to make myself in the best place to do that without then causing complication.
Okay, cool.
But now I'm sort of more confident in that.
Yeah. And are you back running now?
Yes, not as much as I'd like, because actually the logistics of running with a small person is a challenge. So all my grand plans are gone.
Yeah. Is there anything at this point now, 18 months down the line, that you're not able to do? Any exercise or any activity at home or anything you're concerned about?
The only thing that I put on there that might be a little bit niche, so I was breastfeeding until 17 months, so recently stopped and had my first postnatal period, and I found that wearing a tampon just felt really uncomfortable. Whether that is just because I've been on long-term contraception before, so I haven't had a period since I was a teenager. Whether it was sort of linked to that, I don't know. So
okay,
it was very doable, but I was just like, oh, this just feels different to how I remember.
So when was that? When did your periods return?
About 2 weeks ago.
Oh, okay, only recently.
So yeah, I didn't have one all the time I was breastfeeding.
Right. Okay. So is this your first period that you've just had? Okay. And was the tampon, was it the insertion, or was it just uncomfortable?
No, just the wearing of.
Okay. So I suppose it's early days yet, isn't it?
That's what
so
I thought.
we'll kind of have it.
It's just a unfamiliar thing now.
Or sometimes you can have some of the muscles that are a little bit tighter on one side now, and then the tampon's just not quite as comfortable. Or it could be the mucosal lining in the vagina from an estrogen point of view. So, but that's, we want to get you back, being able to do everything that you were beforehand without discomfort or concern. So we'll just note that for the moment. So the date of birth was the 17th of the 9th, 21.
Yeah, so 18 months ago, pretty much.
And talk me through the delivery. How did everything go?
Yeah, really well, really positive, really straightforward. I had my birth plan like we all do, and it was pretty much that. So I had an uncomplicated water birth, quite a short labour, 5 or 6 hours in total. So that was all great. Post-birth, I did retain my placenta. So I had a manual removal of that, and I declined a spinal anaesthetic. So I had that done on the birth centre, which was very uncomfortable, not something I would widely recommend, but that was my informed choice.
Right.
So I had that done, and I had a small 2nd degree perineal tear that was sutured, and haven't had any complications from it since.
And how soon after delivery was the placenta, the manual?
About 90 minutes, quite quick.
90 minutes, okay. And then the 2nd degree tear, sutured?
Sutured promptly, just after that. Yeah.
And no complications with infection?
No, nothing at all. No, bleeding was all fine.
Are you aware of that area of repair? Would you feel it when you're sitting, exercising?
Not at all, actually. No, not at all.
Okay.
Yeah, actually less than I thought. I expected something, but I have to say probably 10 days after I wouldn't have known it was even there.
Right, okay.
So that was good.
And what about during the pregnancy? How did the pregnancy go? Did you have any complications or anything that you had to change or restrict? Or
No, really straightforward. I was comfortable, I'd exercised throughout. I had a pelvic floor assessment at around 16 weeks, again, for confidence. I wanted to keep running in my pregnancy, but I didn't want to cause damage. So for me, it was just giving me that confidence that actually this was okay, and to make sure that I was doing pelvic floors correctly. I wanted to make sure I wasn't just making it all up myself. But yeah, really comfortable, strong, healthy pregnancy, no complications.
And up until what point did you continue running?
My due date, and he was born a day later.
Wow, okay.
I know, but only because it felt good. It felt fine,
Okay.
and it was slow. It was short.
That's what I was about to say. What was the distance?
Nothing more than 4 miles, but in perspective, I was marathon training when we conceived. So for me, it was a really drastic reduction.
Okay, so we've got a runner, don't we, in our clinic today? Yeah.
I can't claim being a runner anymore.
So have you done a marathon? You have?
Yeah, nothing post. Nothing more than the odd 10k now and again. That's it now.
And have you done 1 or 2 or?
3 historically.
3 marathons, okay. And what age are you now?
29.
29. And what age were you when you did the marathons?
So my first one was 18, and then probably each year after.
Okay.
No, that's a lie. I did one the year before. That would have been 26 with my last one.
Okay.
Between 18 and 26.
Okay.
Was my running years.
Are you keen to get back and do another marathon at some point in your young life? Or not?
I thought I did want to. Probably not, no.
Okay.
In reality. Time commitment more than anything.
Right, okay.
Physically, I'd love that challenge, and maybe later on when we've completed our family, then it would be a goal, for sure.
Okay.
But at the moment, I just can't commit the time to the training.
So at the moment, you're running how many times a week?
Once or twice, but doing lots of strength training in between time. We're very lucky, we've got a little gym at home, I've got a watt bike and weights, so I can do that kind of stuff within family life. I do 1 buggy run a week, which is about 5k, and then I try and get out for a slightly longer one on my own if I can, but that's a bit hit and miss.
Right, okay. And at the moment, are you getting any symptoms when you run?
No.
Okay.
Yeah.
So you feel that kind of the tummy, the pelvic floor, everything is kind of
feels okay. Yeah.
And then, as we said, isn't it? Hormonally, Pip has just had her first period, isn't it? So again, that's going to take another 3 cycles probably before, from a hormonal point of view. So it sounds like Pip's doing really well, doesn't it? And so let's kind of screen before you were ever pregnant.
Yeah.
Did you have any ongoing problems with your hormones or any gynecological history?
No, I had historically I've always had abnormal smears and always had a biopsy following them, and then the biopsies were always clear. Postnatally, it was my first normal one.
Oh, okay.
But yeah, I never had any treatment other than biopsies. I never needed to have LEPs or anything like that.
Right. Any history of endometriosis or any challenge with fertility or anything like that?
No, none of that.
And would your periods have been very manageable?
I didn't have them. I had an implant and never had a period. Was waiting for my period. Never had one and was pregnant.
Had an implant, okay.
Stopped them. So yeah, I don't know from a cycle point of view.
Right, okay.
But certainly since I had had an implant postnatally for a little bit, had it removed, and then 3 weeks later had a period. So I feel like that was semi-regular from when I would have potentially ovulated having it taken out. So we'll see what happens over the following months.
But before you were ever pregnant, were your periods regular and normal?
Pre-starting contraception they were, but from about the age of 17 I was on contraception and never had them. I was amenorrheic whenever I had any contraception.
Right, okay. Oh, my brain's now going, okay.
No, sorry.
I know, that's all right.
It was straightforward.
Yeah, I was like, this looks good for you. Okay.
But I didn't have any issues with fertility.
With fertility.
When I decided to conceive, so.
Oh, okay. So you stopped contraception and then got pregnant quite quickly.
Before a period, yeah.
And what contraception were you on?
An implant. Had pills.
Which is, okay. Okay. Okay, I'm going to have to look up a little bit more around that. Okay, no, that's okay. That's cool. Did you have a history of any challenges with your bladder, any kind of urinary tract infections, bladder pain?
No.
Bladder give you any trouble before you were ever pregnant?
No. I'd say in pregnancy I probably had a little bit of urge symptoms where I needed a wee, I needed one now, but that was only in pregnancy, not prior.
And before pregnancy, when you were running or anything, you never had any urinary incontinence? Or?
No.
Okay. Before you were pregnant again, did your bladder fill to good volumes? Would you like empty your bladder every 2 to 3 hours, or would you have ever had bladder frequency?
Yeah, I'd say every sort of couple of hours. I could never be like going a whole day without a wee like some of my colleagues that work on labour would do. Like I did need to go for a wee quite often, but then I drink quite a lot, so I think it was filling appropriately.
Right. And when you go to empty your bladder, there was no hesitancy, or you didn't have to push or strain or anything?
No.
What about your tummy? Did you ever have any trouble with your tummy? Have you got any food intolerances, allergies, anything like that?
No, none of that.
Okay. Never had to have any investigations for IBS, colitis, anything like that?
No.
Okay. Would you open your bowels daily?
Yeah,
easily?
daily.
Mm-hmm. And then apart from the running before you were pregnant, was there, like at the moment now you're doing some strength training, you're doing the bike, was there any other exercise that you were doing? It might have been yoga, Pilates, or mainly running?
Mainly running and strength training.
Okay.
Took up some yoga in pregnancy, because that's what everyone does, don't they? Yeah. You do some yoga. But that's it.
And had you any injuries at all before you were pregnant? With your knees or hips or feet or anything?
I had a hip arthroscopy.
Saw something in here, yeah.
So I put the date in there, that would be more accurate than what I'm going to make up now.
So no concerns on her mummy MOT assessment. Musculoskeletal, any areas of pain now?
No.
And then previously, MSK-wise, you did a left arthroscopy, is it?
Yeah, left hip, yeah.
And what year was that? Or when was that?
I think I wrote it down on the guide bit, so I wasn't sure I did it.
So if I'm looking through the pre-screen, any main concerns? Everything's empty, everything's, which is good, okay? No urinary symptoms, no bowel. Not currently breastfeeding.
No, just stop.
Just stop breastfeeding.
Hence the acne. I think that happened when you stop breastfeeding, like that.
And you had no problems with breastfeeding and initially or anything like that as well, so it's all gone very well. Okay.
Yeah, very fortunate.
You've been doing your pelvic floor. The only issue here is this discomfort inserting the tampon since the periods returned 2 weeks ago, yeah? Do you have a plan in place from a contraception point of view or hormonal?
No, nothing. And then by the end of this year, we'd like to think about having another baby. So, and if it happened earlier, it doesn't really matter. So.
Right. So you're not planning on the implant again or anything like that?
No, I had it removed because I just wasn't getting on with it so well this time. I've had one previously and it's been great. And it was quite a complicated removal. It caused quite a lot of nerve damage, unfortunately, so I don't want to have it again.
Right, okay. Where did the nerve damage?
It went, so the implant was this arm, and it was sort of from here to here. There was a couple of weeks where I couldn't even bend my arm. And now I think there's just some tendon inflammation, which is much better. But for some reason, when she was trying to take it out, it was just causing a little bit of difficulty.
And was it the same type of implant as before? Yeah, it's funny.
In the shortest amount of time, so it should have been easier.
Yeah.
It wasn't. So I've decided that I don't really want to mess around with hormones for a short period of time. So we'll
just let the body do it all just naturally.
See what happens.
And then the only past history we have is the left hip arthroscopy.
Yeah.
And so why did you go for arthroscopy? What was the indication?
So I had this pain. I was quite young when I had it. So I had this pain when I was running and...
So what age? What age were you in 2011?
I would say I was 17, 18, something like that. So like good mums do, they take you to the doctor when you've got this pain when you're running. And anyway, he did some scans and strongly recommended that's what I needed. And when the scans that he did weren't conclusive and he didn't want to do extra scans because of the location, he didn't want to then run into issues with potentially fertility. He kept scanning my pelvic area. So he said he was going to try and do it laparoscopically, and if he couldn't, then he would do some open surgery, and he did manage to do it all just through the scope, but there was tendons that had detached and then cartilage that needed scraping, and he thought that my hip bone had grown at an angle which had damaged the hip socket quite a lot. They never scanned my right hip, but he was concerned that later on I'd have complications with it, which I haven't had.
Right.
And both my nan and my mum had hip replacements quite early on in life. So they're wondering whether there is something slightly hereditary. But actually since that, it's been great.
It's been fine.
He said I would never run again, and I've been fine. So
yeah, exactly.
It's really reassuring.
Yeah.
I was there at like 17 or 18. Yeah, it was thrilling.
Okay, so then...
But yeah, actually I'm happy with it.
Yeah. So it may have been a little bit of a genetic predisposition, may
Maybe.
not. Do you ever remember injuring it? I don't know, like when you're playing football or doing something. There was never an injury before you were 17 that you remember?
Perhaps. I was into horse riding, and I remember being flipped up on a gate, and that was quite painful for a little while, and I always wondered whether it was linked to that.
Flipped onto a gate or where?
Upside down, so the gate post went down my riding boot. My horse galloped off, and then I was upside down on the gate. I mean, I was
upside down on the gate.
It's fine. But maybe that
okay.
In retrospect, if this was me now, I wouldn't have jumped straight into surgery. But that's what you do, isn't it? You just do what the doctor tells you in that age.
And can you remember what discomfort or pain you had and where it was?
I remember it radiated right from my hip, right the way down to my toes.
Okay.
And it stopped me running.
Right.
I remember finishing a race and being pale and in absolute agony, as opposed to just exhausted from running.
Do you remember if that pain was like a burning, a throbbing, a shooting, a type of...
Off memory, I think it was more throbbing.
Throbbing. Okay, and then the arthroscopy relieved all those symptoms?
Yeah, actually it's... I mean, it was a very slow process. My now husband's a sports scientist, and at the time was doing a lot of work in rehab, so he kind of did the rehab for me. And yeah, it was slow, but I got there, and it's been good since.
And do you feel you have any symptoms in that left hip now?
No, and I was surprised in pregnancy.
I was about to say, it didn't pop up yet in pregnancy.
No, it was good actually, really good.
Okay, perfect. Any other surgery anywhere? Have you had any abdominal surgery?
No.
Have your appendix, gallbladder? No.
All inside still, yeah.
Okay, perfect. Okay. All right, let us get on and do a mummy MOT. I was going to, as well, you haven't had any other medical conditions that you've been diagnosed with? Nothing, no autoimmune? Medication, are you on any medication at the moment? No. And previously, have you been on anything other than, say, having the implant?
No, nothing.
Right, okay. So what we're going to do is we're going to look at your posture. We're going to look at you doing some functional movements, check your tummy, check your pelvic floor, and it sounds like you're doing really well, and we just want to keep an eye on this left-sided. Check if there's still some kind of tension. You know the way you can have tension, or you can have a little bit of dysfunction, it doesn't give you symptoms, and then over time you cross over that line. So we want to make sure that you don't, that you can continue to run and continue not to have any symptoms. And then we have to think about this tampon. Is it just pregnancy, hormones, and the vaginal tissue's not quite ready?
Sure.
Or is it something a little bit that the muscles are a little bit tighter on one side? Because over time you want to have those to get rid of that discomfort.
Definitely, yeah.
Okay, so we're going to, I'll look at you in standing, and Alex, my colleague, is going to come over here now and help us with our screen. I'm going to take this out of the way. Maybe give that to you there.
Them having their copy,
or we've only got one copy? No, I've got lots of copies because in the afternoon I was going to get you to do that as well. Oh, a copy of the assessment form. Yes, that's a good idea. Yeah, let me get those. So that you can kind of see the what we're following through. Sorry.
Just trying to think, how comfortable are you taking things off or rolling up?
I'm a midwife. Of course.
of course.
I'm fine.
Yeah,
Although, remember I didn't know about this, so I haven't shaved my armpits and I haven't got my I arrived at Paddington Station as I got Maria's text, so don't judge, guys.
Oh, we're just in awe of your muscles instead.
Oh, no.
Yeah.
Do you want me to take this off?
I think that would be all right,
Okay.
actually. Yeah, you can probably
Shoes
just
off?
roll it up so that we can see your abdomen. Yeah, that's perfect. Yeah,
Do you want my shoes
yeah.
off?
I think that'd be good. Yeah, have your shoes
Yeah.
off. Yep. And maybe socks too, if you're comfortable with
I
that.
haven't painted my nails though.
Oh no, that's it. Got to stop the assessment.
Don't see me in I've got runner's feet without painting nails. Don't see one on the feet.
Fantastic. Okay, so we'll start looking when she's just going to come with these bits of paper. And when you get the bit of paper, it will come down to the functional assessment just there. That's where we're starting, isn't it?
Should we pass those around?
Yeah.
Okay, so I'm just thinking of the best position. If you want to maybe face that way. So we'll just look at her to start with. Let's look from top to bottom. So, yeah, that's fine. Okay, so we're looking to see what can we see. So we've got some good upper traps here. We've got a little bit of, what have we got there? A little bit of protraction. Yeah. Following the spine down. Okay, and I'm just going to roll this down slightly.
I haven't got the best underwear on again.
That's right, I'm taking them with me.
That's alright.
Okay, what I might do actually is just turn you to face the wall just so they can see you from behind. On the mat, yep. Okay, come stand on the end of that mat. Lovely.
And sometimes if you're up very close, that's good to see, and then sometimes it's good to kind of, you get a snapshot from the distance. What are you?
So we can see how she's standing. So you can see straight away she puts this leg forward slightly. If you just march on the spot for a couple, say 1, 2, 3, 4, 5, and then stop. And she still likes to put this leg forward. Yeah, do you see that? Just slightly there. It's probably about a centimetre, yeah, like one finger. So already I'm starting to think, oh, a little bit of torsion. Yeah, on that right side. We'll come back to down here and let's have a look. And we're just looking to see what her PSIS are doing. There's a slight dip on this right side. And then if we look to see here, we see what these, and then we have the similar translation above that. Can you see that? With the iliums, the top of the iliac crest, slightly lower on that right side. So you start thinking, oh, does she have a leg length difference, or is it just muscular contraction slightly different, or is it just where she's putting that leg slightly forward?
Which was the hip
The left, yeah. So she could be just over time has
Interesting, isn't
just
it?
offloaded
Has
from
this-
that left side. I would
Yeah, has
imagine,
this one always had the brunt because it's slightly
Yeah.
centimetre difference, or, you know, a torsion thing?
Pip, are you happy to put your beautiful hair up just out of the way so we can kind of see your shoulders and shoulder blades as well?
Lovely. Okay, so I'm just going to follow your sheet because you've got it there. Obviously, sometimes you go towards what you're finding, so I'll try not to digress. So let's bend forward as if you're going to touch your toes action to as far as you're happy to go to. So we're looking then to see, what do we see? As she went forward, I saw it straight away. You see on this side? So again, there's that slight torsion. I mean, emphasising here, it's not massive, but again, it's coming to that side.
Sorry.
And any discomfort for you? Are you feeling any pain?
No.
You okay? No? Good. And then come back up. Okay. And then we'll go backwards. But what I tend to do is just get them to put their thumbs here for a bit of support. And that just gives them a bit of a reminder of where to go. And they're bending back and keep your chin tucked in for me. That's it. Otherwise they tend to do a bit of this. Yeah. And that's pretty good. Again, but hinging
Quite
a bit
mobile.
lower. Bit more like T-spine, T12, just as she comes down. But she has got some extension there.
So you might find that, I haven't looked at her tummy yet, but you might find that then abdominally she's a little bit less tension in her linea alba at that point. I think that's something
Yeah,
to-
so exactly like that ring analogy, you think, right, what's on the other side of that ring? Yeah. Okay, and then next one on your list.
So that's spine. This is where we are, yeah. Spinal flexion, extension, and then it's also actually if you turn to face the door, Pip,
We'll see the
and just do your flexion and extension once more for me, because you're just observing, isn't it? And you know, Diane Lee used to say, just look at it. What does it look like? Where does it look like there may be a challenge?
You see here.
Yeah. And then note that, and
Yeah. But she's very good. She's aware. You can see she's holding that, keeping it in. Whereas a lot of mums will just maybe let it go. And if you were to not hold don't hold your abdominals. Just go into that back bend. she's hard for her not to because she's know it's automatic,
Yeah,
but she's
right.
slightly bulging here. Yeah, and then come back up. That's good. Excellent.
And then what organ would you find here under that slightly transverse colon? Yeah, just keeping that in mind. And then we've got stork.
So stalk, we all know from there, from that region. So you're going to lift up your right leg for me, just lift it up like a knee up in front of you as far as you go to about 90, that's it, lovely. And then coming back down, and what we're looking for if there's any juddering, any instability, any sway. So do that again for me. It's fairly stable, but there is a little bit of juddering going on. And the other thing, so I'm going to turn you back round again.
Not on one leg.
No, yeah, that would be impressive, wouldn't it? Yeah, you've passed now. So if we do that again, I'm just looking at what these PSIS are doing as well, and if we're getting a good translation when she lifts, and then back down. But the more she does it, the more she's slightly fatiguing. Notice that. Okay, and then let's do the right, bless you, let's do the right leg. A bit more tricky. Yeah, and we was like bending the knee, slightly bending there. She's hitching here, hitching in this part, so we've got some instability there, and then come back down. So
she's rehabbed that left side so well.
Potentially, I mean, when you do a stalk on that leg, what side of the core is it testing? Is it testing this side of the core or this side of the core?
This side.
Yeah, it's testing that side. So when you put it down, you think, oh, it's testing this side, but it isn't. The stability is actually testing what this one's doing, and can it support and hold you? So that's already saying to me, there's a dysfunction around her left side. Okay. Yeah. The other way we might see that, which isn't in the book, but we might add it in, is what the osteopaths do is like a gossip. They call it a gossip. So when you're standing and you just sort of, what's going on, man? Yeah. So we call it the gossip. So what we're going to do is just bend your right knee, let it flop. That's it, good. And what that's doing is just again testing what the other side's doing. Come back up, and the other side. Awkward. So yeah, that's sort of and it's a bit sticky through that side. Yeah. So it's a nice quick one to do, and also they can. Did you feel that? They often can feel it. Yeah. Whereas when they lift the leg up, they don't. They can feel the shakiness, but they can't feel any sort of weird dysfunction that might be happening. And then next on our list, I think we've got gait on there, haven't we? But
and I was just thinking, Pip, if you turn towards me as well, if you've got a mum and it's like 6 to 8 weeks, you're going to get watching that transfer load, isn't it? You might ask them to do it for 2 or 4 seconds. Whereas now that we're 18 months down the line and she's running, we want her to get into that stalk and to maintain it for 15 seconds. We'll go through that tomorrow. So, you know, we're further down that postnatal recovery, so we would kind of challenge you a little bit more. But yeah. So what would we say there? Would we say that we had a positive stalk on which side?
so if she had it and she was lifting up, so the positives on her left. So the left is the dysfunction.
Yeah. And we know that there's some kind of tightness and things there. And then where I am here, you can see that there's a little bit, there's a little bit more tightness shift here, which you felt when you did your, what's it called? The gossip.
The gossip. Okay. Yeah.
And that would, it may link back, isn't it, to this left hip and the arthroscopy and everything. It's probably that, but we may find something else as we go on the journey. And then we've got that hyperextension, isn't it?
Because the other thing that happens in an arthroscopy, like a hip arthroscopy, is they actually add traction in order to get to the joint.
Okay.
So if you had a lot of myofascial tension from falling off that horse and the pull and everything, because you said it was radiating down the leg, well, we know that something that maybe a ligament or a tendon, it's mechanical. So it'd be like, ow, it's when I do that, or ow, it's when I do this. It's not, it radiates. That sounds a bit more myofascial.
I remember it like radiating all the way down.
Yeah, it's not quite a normal of a specific injury. And
the other thing you can see from the distance here as well is, isn't it, that there's definitely overactivity here in these left external obliques, so they're kind of compensating for something somewhere. So you're just kind of noting all of that as well as they're doing the tests. Yeah.
Okay.
You got a squat.
And then a squat. Yep. So let's see how she. Yeah.
Sorry about the knees.
Yeah. So we just do a few for us, just a couple. So then again, it's nice to get an idea and maybe slow it down a little bit. She likes to use momentum.
Sorry.
That's all right. Yeah. So then when we go slower, then we start to see
What can
If
you
there's any
hear?
Crepitus in those knees. Yeah.
In both knees.
That has always happened.
Is it?
Doesn't hurt, just sounds horrendous.
But we're looking to see, is there any shift? Does the knees wobble side to side? Does she grip in a different place? She's got fantastic in her lower, and she's still great here, but could do this smidgen more at the top. And again, we may find that there might be some laxity there. Yeah.
She doesn't have tight calves or anything, so she doesn't. Those of you MSK wise, so she can get like a really good
Keep going.
depth.
Now, the other thing is
down.
when she goes down, she twists this hip in, this leg in. Again, does she do that maybe because that side's a tad longer? So as she gets lower, she then has to twist that right side, their left side in. But
Offloads our hammocks as well on that side. Offloads our big tray, so the torsion, that's
Yeah.
reloading.
so we could then, while she's doing it, see how good her lift is. That's not so bad actually.
Focusing on the toes,
But-
guys.
Yeah. Yeah, she's putting a lot more weight over here, and this one lifts. See?
You've got good endurance there.
Yeah, she has. I was going to say, she keeps going like a jack in the box. Yeah. All right, you can stop. Yeah. Let's add in a lunge now. So, do for us what you know as a lunge. Nice. Another click. Kick it click. Yeah.
Sat on the train this morning.
Okay.
And if she was early postnatal again, you want to make sure that you can do the movement, because this might be some of her exercises that she's going to do at home without giving any of her symptoms. So she may say, okay, I can go as far as here, but then after that I feel like I've got a leak, or I feel that there's heaviness. And also you're going to look at their breath. You know, definitely in that early stage, 6 to 12 weeks, you want to get the breath right. Now Pippi is holding her breath a little bit, but it seems to be, she's still managing pressure pretty well everywhere. So as you're testing it, sometimes you'd be noting that. If they're like holding the breath, well, before they go home, you're going to say, okay, let's redo that, breathe in, and then breathe out when you're doing your lunge or your squat, whatever the...
The physio that I saw when I was pregnant, we had that exact conversation because all I did was breath hold.
Yeah.
I didn't
Yes.
know about breathing
Yeah.
with your pelvic floor and exercise until that point.
Yeah.
So then trying to learn it after years and years of weightlifting and just holding my breath, I
Yeah.
found really, really hard.
And what would you do now when you do your strength training? And do you integrate the breath or...
I do try to. If I'm doing a heavy lift, I don't.
Mm-hmm.
I just can't in my head.
Yeah.
do
Can't
it. But if
coordinate
I'm
at all.
doing, if I'm doing like lower intensity, higher rep stuff, then I do really try and use my breath.
Yeah. Okay.
So when you go back to lunge, another thing, when it's early on, it's going to be tricky for them anyway, and you're going to see all sorts and come up and imbalances and things. But where she's a little bit further on, when she does that lunge, you're going to try and get like a 90-degree angle at both knees. So sometimes they will cheat a little bit and they'll just come, here's my squat. Yeah, so then we've got knee over ankle. Actually, that's a smaller base of support, so then it's easier to do. So if we do that lunge again, but just aim to be a little bit more at a right angle, so even still, she's still a bit over. So if you bring this a little bit more forward, yes, there. And now if you just go up and down in that position, that's going to test that stability just that little bit more, and she'll start to quiver or maybe move a little bit, only in her situation. Yeah, just a little bit further on. Okay, and then swap legs, because we may find something different on this one.
She's an amazing breath
Clickety
holder,
clack.
isn't she?
Yeah.
I don't know how she's still alive.
Yeah. So we get a little, when she gets to the top, we get a little,
Yeah.
little twist there. Yeah. Good, and okay, perfect. And then come back up. All right, and then the last one on the list there is the...
We skipped the walking there, but you could get her to walk on the corridor. If you have a treadmill, it's quite good actually to get them to walk for a little while on the treadmill. Especially if you're if the picture's looking a little bit complex from an MSK point of view, because if you think about it, we're doing these tests and Pip's on our best behaviours, and we're just looking at like a snapshot, but we're not looking at what happens when she gets tired after 3 minutes or 5 minutes on a treadmill. There's a little bit more advanced as well, but we'll check those later. We're going to keep it simple for the moment. So we've done those tests, and now we're going to get you up onto the bed.
for tummy, is it? Yeah, next one.
Yeah.
Next is tummy.
Just lying on my back.
Yes, we'll move that pillow there. Move that over. Just so I'm following the sheet of what you want. Okay, so this is coming. I don't know if you can see from there or not, but we will be looking at the tummy. One thing I tend to like to do, just because I come from a visceral point of view, is I like a little bit of tissue to just pop in the trousers there. Is there a little bit, or maybe we could use the this towel? Or use the towel? Yeah. Okay, perfect. So what I do, because there's actually this whole space here that we may miss, and especially if you've got a C-section, yeah. So we pop the towel there, and it's really good at keeping everything in its place. So you want to get to, you see a little bit of pubic hair. Yeah.
Yeah, don't repair that either.
Don't be afraid of the pubic hair. See, so now we've gained all this space here, another good 2 inches, yeah, that we probably would have left out. So we're looking from the top, and that's here. So we're looking to see, is there any bulging? Where does the breath go? So we can see the breath sort of a bit more like this, isn't it? Doesn't tend to come here, because this is where she grips a little bit. And then we're looking to see, are there any scars? Do we see any scars? No, can't see any scars. We can look at temperature just to see if there's any temperature changes, especially if someone's coming with pelvic girdle pain, to see if there's any bowel involvement here. We're looking at the belly button. Is the belly button gone back nicely? Is it coming out into a little umbilical hernia? So we're looking at that too.
And by the time you check here as well, because you've seen what's happening when she does a squat and a lunge, you'll have an idea about the tension already in her linea alba, and whether there is, as I said, a hernia or a diastasis. We saw, didn't we, a little bit more overactivity of the obliques, which means that something else might be a little bit underactive, which we may find as we go along.
Yeah, looking at rib flare as well. Some people you will see one side may stick out more. If it's on the left side, what do we reckon that could be? What organ have we got mainly on that left side? A little bit more central, and up here we've got heart, but here we've got the stomach. Yeah. So again, if they've been saying, oh, did you have any acid reflux? Did you have that in pregnancy? Then you might see this flare, because it may not have come down properly. And then on this side, what we got this side? Liver. Perfect. Yeah. So again, both of them should be down. They are down with her. All right. No, that's good. But there is a little bit of like gripping here. And on this side, well, right, see, it's gone, yeah, hello, you're touching me, yeah, that's good. And sometimes I do having a little laugh or a cough, helps us to see if there's any bulging or anything that happens. So let's have a little cough. Yeah, so it's not bad, but some people will go boom, boom, and breathe out this way rather than in. So that's something to look out for. And then a laugh. Perfect, yeah, and again, so we're looking to see what bulges and what doesn't.
If you're looking down at her feet, the position of the feet here, you can see that there is kind of like asymmetry there, can't you? What do you see, Iona?
A lot more external rotation on the left.
Yeah, so it's either a lot more relaxed, or this side might be. So it might be that this is
how I always
tight.
The left one, yeah. Often when the piriformis is tight, it will do that. It will pull that leg out more laterally. But the piriformis, you need to check it below and above 90 degrees, because it has a different function, one internal and one external rotation.
And that would match what we found with our gossip, isn't it? No?
Yeah.
And so you also just want to double check that it's not tight on that right adductor to compensate the weakness on the left.
Yeah, that too. Yeah, so you can check all of that fascia underneath there. You can come through here, and you can just have a little feel to see what's that feeling like. Yeah. And obviously compared to the other side.
So we kind of noted all that. Then we're going to go with our active straight leg raise first.
What's that first? Yeah.
So, do any of you do active straight leg raise in your assessments at the moment? Yeah. Okay.
So what we do, active straight leg. Okay.
Just lift up.
Yeah. So if we do it with I like to do it with the foot coming up towards you first. Lovely, and then we just see what she does, and as far as you're happy to go to. Yeah. Excellent, and then come back down. So just at that first point, you can do it to about 6 inches, just to about here.
Lower.
Nice. So then we can start to see what happens here. Does she have a little torsion? Does she lift? And she's sort of grabbing here. So again, when we're lifting this leg, what side of are we testing for the core? The opposite side, yeah. So this should be a little bit more here, see? And then come back down. And then let's see what the other one does. Woo. So actually she was quite good on the other side. And then this just confirms our hypothesis over there of that there's something slightly dysfunctional happening on that left side because we've got a lot of rotation. Yeah. And that's something we can work MSK wise with her. Yeah. Good. And then now she's thinking about it, she's talk. Good. And then maybe we'll do it next in a bridge. Yeah. So if we come up, you remember what a bridge is? Yeah, lovely. And what's good to think about here is thinking about just get a tennis ball width in between their knees. I like to give them that visualisation. And even when you get that visualisation, they can still make mistakes and do this or do that. But it's good to just give them that heads up, and then that gives you an idea of what they're going to do. So from there, just going to tuck your tailbone under, and then we're going to be lifting up your pelvis till it's level with your knees. And now let's see if we can lift this left leg. Keep those knees straight. So she drops a bit. Do you see that in the pelvis? And then bring it down. That's all just the leg.
Oh, sorry.
That's all right, yeah. But that's hard, isn't it? So come back down. Let's do it from this position. We're just going to lift the leg straight from that position. And I want you to lower it to about 6 inches off the bed. And hold. Good. So just again, slight rotation, but not too bad. But we're looking at what this leg does. Does it flap around in the wind? Yeah, and then come back down. Excellent. And then when she brings it back, imagine you've got that cup of tea there. Can it be balanced? Will it be spilt? So let's check the other leg. So you're slowly going to lift that leg. Good. And then slowly lower it down to about 6 inches and stop. Good. Keep breathing. and then bring it back to the middle. And let's see. And then slight adjustment, but not too bad. The reason I went straight into the bridge is because I knew she wouldn't be too bad in this position, but actually with your 6-week ones, you really want to keep to this position. But we could go back to that and test the other side. So when you lift up into the bridge, hold. I'm going to lift this right one up, but only just lift so the leg is level. Yeah, that's it. Yeah, good. Excellent. And now you're going to bring that back down, but don't move this pelvis, don't move this pelvis. Good. And then slowly bringing that down. Excellent. And even that last bit, when you're coming down, do they go blonk? Yeah, or do they curl it down nicely, or is there juddering that happens?
I was thinking just on that active straight leg raise, could I just go back one step? So if you're checking your active straight leg raise, isn't it? Like Alex, you don't want to go too high, but you want to come to here, and then you want to ask the patient as well, and come back down, and then the other side. Is one heavier than the other, and come back down. So that one's heavier.
Which is again testing this side.
Which is testing the other. So that gives you a positive. And then you can, again, because Pip's further along that postnatal, so if you lift this leg up again and then match my resistance, you can check that a little bit more yourself. And that's useful to see what's happening around the linea alba, and is there a little hernia, or is everything okay? Is she managing that extra load and the pressure on the other side? And then there's not as much strength there. So that would give her a positive active straight leg raise on the left, yeah? And again, if you had somebody who had pelvic girdle pain, then you might then, and she lifts and she's got pain, then by doing your compression, and that takes away the pain, that will inform your clinical decision making around she might need a little bit of support. And Pip doesn't have a very significant diastasis, or it might be like Diane Lee does, you would bring the tummy muscles together and do your straight leg raise. So we'll look at that a little bit later in a little bit more of a lab. So you're looking for heaviness, pain, and then what you might be able to change to improve that if it's positive. Does that make any sense on the straight leg raise? Yeah? Okay. Then we have our Fabers.
Yep. So coming up with Fabers, you're testing that hip movement coming up to there, and we're seeing, can this leg relax on this one, and can we drop that leg out to the side? What have we got there? And the hip actually does go quite nicely, but this comes with it again. Yeah, but there's no discomfort for you, and there's no irritation there. And when I restrict this side, it's still good for you. Yeah, I feel like this will keep going, but there's another aspect that's happening. And then to this one, doing the same, put the leg onto there, and then she rotates a little bit again, but the hip itself goes quite nicely. Yeah, good. Okay. Okay. Anything else to add on that one?
And then with the knee bent, so that we do
yeah,
it leg
so we do it
straight
a bit-
and leg
That's
bent.
it, yep. So we do it in a little bit more of a position here. Does it go out to the side? Really easy on her, but some people will be up here. Yeah.
So that's giving us a bit more indication around the hip rotator muscles and
Yeah,
the
and
tightness.
piriformis. And then bring this one up and this one again onto this side. That's it, lovely. Yeah. Now this one looks interesting. You see the difference on this one?
Yeah.
She's really hitched that to bring that one round. So let's restrict her. Let's bring you back to the middle. Right, and now do it.
That's where she was also hyperactive on
Yeah.
the external.
Yeah, it doesn't want to
Yeah.
do it, does it? So where, do you
It's
feel
that
anything now I'm
cross-swing
restricting
here,
here? Is
I mean, I'm not trying to push my leg out. I'm just letting it.
okay.
Lock.
Yeah, and if you were to put, what do you feel? Anything? You know, because
It's
you're
tight here.
yeah, because you're recruiting that, so that mechanically doesn't want to
No,
block
it was
out.
the other one. I'm just letting go.
So has this side been overcompensating all this time, but then become tighter and weaker
Yeah.
to then compensate for what's happening there? More to look at, more to find. Yeah, but we're
So-
picking the
Yeah, no,
so,
it's good.
yeah.
So there we've looked at active straight leg raise, bridge, single leg bridge, and Faber's. What is anybody kind of putting together in their brain or connecting? I can see Kirsty, isn't it? What are you thinking? MSK, biomechanical, or even sling systems? What do you think is going on so far? What are you seeing so far?
As I say, I think we'll go back to the visceral, but the sling that we're coming across our material.
This way or this way?
That
way, yeah.
Because we've got the tightness coming on the external obliques that we're saying we're over-recruiting. So also we've got some length issues around the pelvis, which is obviously we're seeing that sort of torsion element happening with coming into single leg activities as well. So again, we know we've got some pelvic instability going on on that left side. And we're compensating abdominally for that as well.
And then you wouldn't say pelvic instability, sure you
No,
wouldn't to the
sorry.
patient, yeah. No.
Yes.
Or you might say some pelvic, what's it, altered alignment
Yes.
or, you know, compensation. Yeah. And again, Pip isn't getting, you know, when I screened her earlier, she wasn't saying that she's got any symptoms and she doesn't want to run a marathon now. Maybe she will, maybe she won't, who knows. But we are finding, aren't we, some discrepancy and altered biomechanics a little bit. So it would be good to come up with what to do to correct that if we can.
Yeah.
Okay.
And another little golden nugget when you're thinking of someone, if they're restricted in any hip movements that are going out or in that favours, is to look at the opposite again, the SIJ on that side. Yeah. So when she did the gossip on her left side, so when she dropped her left, that was dysfunctional. So it's seeing what this side of the SIJ is doing. So
And
then
also like the quadratus lumborum and thoracic.
exactly, yeah, because that further up is then tight on that side. Yeah, so again, it's reinforcing that.
And then come up into you're going to go back up into your bridge.
Yeah.
If we remember in standing, wasn't she? She had that really kind of hinge there. So it would be good for when she goes home, because you can send her videos and you can send her, but you need to send her 3 exercises or give her 3 exercises that are going to change something. So you're going to breathe in, so we're going to start to integrate the breath, and then you're going to breathe out and you're going to come down. And as Alex said, come down as slow as you can, and then keep that tailbone good until the end. We want to get that segmental control at the back, that last third of the way down. Breathe in. So okay, and then breathe out, come down, tuck, tuck, tuck. Actually, that's quite good, isn't it?
It's just getting better, isn't it?
Breathe in to prepare, don't move, but breathe. Good. And then breathe out, pelvic floor, come up into your bridge. You know, she's really steady and strong. She's not drifting off to the right or the left there. Breathe in and then breathe out to come down.
Yeah, she's working harder now to bring this bit down instead of just from belly button down. Yeah.
Being less lazy.
Yeah.
Saturday would be very different.
Yeah.
And we really are, we're trying, we're trying to find.
And I think that's been an important. I didn't come to you with any symptoms, and that's why women all need to be screened, not just
Yeah.
with symptoms, isn't it? That's the whole point.
Yeah, because it may lead to issues in the next pregnancy or
exactly.
something like that. So it's good to screen it, yeah.
The other thing I was thinking, sometimes you may, if you straighten out your legs, you may have to adapt the position if she gets pain as she lies with her legs straight. You don't want to give her any extra symptoms when she's come for her assessment. So we're going to do we're going to check diastasis now. Pip hasn't said she's no concerns about her diastasis. Do we think she has a little bit of a diastasis or not, or?
What do you think? Should we have a look? So we'll test from the top first. So we're going to place our fingers and we're coming from that apex. Always important to go right from the top to find someone's apex, because sometimes it might be up here and you've missed a whole load. So come from the top and we're feeling down. You can feel this way if that makes it easier to see. And we're looking, and we're looking for integrity. We're looking for if there's tension, and there is. For me, there's a little bit of a bulge here coming this way, but the good thing is I'm not sinking there. And we're coming down, and then a little bit over her belly button. Yeah, so it's about 2 fingers for me, of my fingers. Yeah, this is where we start to become like, how objective can we be? So I always say of my fingers in the notes. And then she comes back down, we're completely together here. And then always good to go right down to the pubic bones. This gets missed as well. Right the way down, because some people start to separate further down. But she's not. She's all lovely, lovely, lovely. Good, good. Belly button. Comes the 2. But it's still good integrity. Yeah, so it's functional. Yeah, and then we're coming up, and then she doesn't have anything up here, but there is this interesting little bit of a bulge there for me this way. Yeah, so now we get to actively join in. So if you look towards your feet for me, let's see what she actively does. Lovely, lovely, lovely. Again, slight bulge there, but that's good, 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 good. And then she comes one and a bit, but nothing, 1. But it came down from 2 to 1. Nothing. Yeah, and then come back down. Is that all quite clear? Yeah, so she's quite good there. Some, when they bring their head up, you may be like, whoop, you can just sink through. Yeah, so the integrity is not there, but they may still be functional in that they can contract it and they can hold it. But then when they're relaxed, you might be able to get 4 fingers in. Yeah, but that doesn't mean, oh no, now you need surgery sort of thing. As long as they can, when they're active and functional, whoop, they come back, then that's good. Yeah.
Is the bulge like in line with where we saw the hinge on the extension?
Close to, slightly lower, but it's very difficult to say when people have had babies, because normally the belly button lines up with L3, but once you've had children it slightly drops. So in her case, her L3 is probably a little bit higher just because she's had a child already. But then she's got good tone, so she's probably brought it back up. But there's a possibility, but I think we'll find it's more at this point, round more to T12 level in her case. Yeah.
And you generally find that there is more challenges above, don't you?
Generally
above the
above.
tummy button, from about here. And if you look anatomically at the different layers of the muscles, the internal obliques and everything, they go under the linea alba here, whereas below that arcuate line here, they go over. So generally, it's easier to regain that tension below than above, but not always, because it could depend on a few other factors if you'd had previous surgery below. But yeah, so I don't think I know over the years you can get out like a measuring tape and bring it from here to here, and you measure half the distance. That's what Holly Herman and Diane Lee recommend. Then there's another physio who's an expert on this in Portugal, and she recommends 2 and 5 centimetres above and 2 and 5 centimetres below. But then I feel you're missing out, an awful lot. So you want to think, what is the tension, like Alex did there, all the way down, and then what's happening when you add head lift and
thinking like a ring again. Always thinking like a ring, that if there's something stretched on one part of the ring, then there must be compression on the other side of the ring. Yeah. So we look at when hers is, which is here, and then we've got this suspect bulge here, which I think is to do more with an organ. in itself, but once we adjust your diaphragm, then we want to look at the back to see what that's doing. But we could easily probably bring her 2 fingers down to 1 today, and I can show you how.
Doing a bit of manual therapy,
I
isn't
can
it?
show you how. Yeah. Stop her gripping with this bit. Yeah. Okay, and
Then we are moving on to
4 points.
active straight leg raise, core synergy.
Yes. So we need to get on all 4s for this one.
Yeah.
Yeah. Is that all right?
So core synergy, that is where you
maybe
are
if you're
drawing your
balance
pelvic
it.
floor up and drawing your tummy in at the same time. So again, early postnatal, that's what we want mums to be able to do, and the video show you all that. They need to be able to, on that out breath, draw the pelvic floor up, draw the tummy in. And in all positions, sideline, supine, sitting, and on all 4s.
Yeah. Oh, sorry. I thought we were doing the 4 bit. Sorry. We need to do the
With the
general
diastasis,
course
is that what you're talking about?
Yeah. Sorry,
Okay.
I was doing the diastasis
Got,
again.
yeah, okay,
Because I was on
Alex is
diastasis.
still on the diastasis.
I'm on the
yeah.
diastasis running.
Actually,
That's
let's stay on the diastasis because,
Yeah,
keep
sure.
it simple. Yeah.
Back to all fours.
Back to all 4s then.
So the back sheet of your mummy MOT is again probably from 12 weeks onwards, or at any point after that 3 months, which is where Pip is. So on all 4s, you're going to see what's her transversus activation like, and can we get Pip to, I mean, she's doing so well holding this breath, isn't it? But I still feel that really we need to
What do you do when she
get her
breathes
to
in
let go a
normally?
little bit.
Yeah. Yes. Do some nice. Maybe.
I'm sure I must be one of those people with like a pelvic floor that's just like steel tight.
So it's like breathe in for 2 seconds and breathe out for 4. Think of it like that.
So you want to go, let go.
That's it. Let all this go. Let all this go. She doesn't know how to let
Like
go.
I am.
Yeah.
That's as relaxed as as Pip goes.
Yeah. So just a bit hypertonic
Try with my husband.
all the way
also.
around. You're just gripping. Yeah. So we'll feel around that belly button. But again, she's got very good function there. And we're just seeing, again, there's that section I said about that wants to come out just here. Okay.
Yep. And if you do let go a little bit and then
Try it.
I'm really trying.
She's really
I
trying.
almost feel like I'm pushing out.
If you let your pelvis go, let your pelvis relax.
and then are you able to draw your tummy button? So you're just going to draw in on that out breath.
That's
Breathe
it. There
in,
she goes.
good.
Yeah, there we are.
And
Let me
then
see
breathe
this
in, release. And then breathe out, nice long out breath, slowly.
Good.
And then let go.
So you can see from this position more how this top bit doesn't go in. But when you get to the breath, she's now lengthening. Because it's important to be able to lengthen and contract, yeah, to get a good activation. That's better. Can you feel yourself letting that go more now? Yeah,
I felt like I was trying before.
Yeah, that's good. That's a good cue.
Then when you've got that, then you want to get them to go up into their box. So then
Coming up
the
on
box
your
is
knees.
going to tuck your toes
Tuck
under.
That's it. No, just just lifting the knees just slightly up. So that's it. So you're in that position. Yeah, good. So the same applies then. Breathe in. And as you breathe out, pulling that belly button towards your spine. Yeah, good. Excellent. She actually engages better a little bit with that one. Yeah, but she's really hanging on with these shoulders. Yeah. Yeah. And then come back down, give yourself a rest. Yeah. Okay.
And then we've got super mum and downward dog, which
We do arms first, maybe on their own first. So again, you might think, oh, let's do both together, but they probably do that and they might fall over in 6 weeks. Yeah. So if you do one arm at a time, so we're going to So but before we do that, we're going to do the engaging first. So we're going to breathe in, and as you breathe out, drawing that belly button towards your spine. Good. Now lifting this arm off the bed, straight ahead of you. Good. Keep that there. Good. Breathe in. And as you breathe out, drawing it back in again and bring the arm back down. Good. So always breathe out on the exertion, like on the movement. Yeah. And the other side, so breathing in first and breathing out, draw the belly button towards the spine, hold, arm out. And again, we're looking to see, does she wobble, does she sway, does she twist? But she's not, she's doing really well. And then back down. In her case, we just have to make sure she is breathing. That's her main thing. Which can fit again with here, why she's got this restriction here, because T7 is witness to the diaphragm. So if you've got T7 to T12 that's stiff, and we've got a tight diaphragm. Yeah. Good. And then we can go for a leg. So we can do the same again. Breathe in, breathe out, drawing the belly button towards. We can go for one leg, kicking it out. Yeah. Lovely. Good. So we're looking for the weight transference. We're looking to see, does she sway? She's very good. And then bringing the leg back again. Remember to breathe. So she shifted a little bit there. Yeah. And then the other side. Breathe in, breathe out, and lifting the leg. So this one definitely transferred more weight, and she's swaying now. So again, we're testing that stability. And then breathe, come back down. Or it was like almost getting your leg over something then, wasn't it, to bring it back in. Yeah, so that was quite awkward, wasn't it? Good. And then you can do the two together. So you can do arm and the leg together. So breathing in, breathe.
Opposite
sorry,
sides.
breathe. Yes, yes, opposite side, sorry. Breathing out, opposite side, this leg and this side. Yeah, lovely, good. And we're looking, does she dip? Can she control it? And she does. And this side, she's pretty good actually. And often you find when they do them together, because they're using it as a sling, this then aids this. Yeah, and back down. Good. And then the other side, breathe in. And breathe out. Whoa, okay, there's a big twist there. Yeah, she's like, oh, not sure on that one. Yeah, and then come back down. Good, but this is all work for tomorrow. You're going to have fun tomorrow doing all that work. Lovely.
And then bottom back on your feet and just rest, you know, like that nice shell stretches. After a lot of these, and again here you can see again, isn't it? You can see that it's tight.
Yeah,
Here,
the rotation.
here. So it's just good as well then to get, as I said, because when you're doing these tests, you don't want to create any discomfort. So again, just reversing that position, and then it's good to get them to take a nice breath in into the back of the body, isn't it? We want to, and then breathe out. We want mums to breathe 360 degrees. Breathe in and breathe out. And again, tight on that left.
This is actually
side.
a nice position to mobilise. So if you've got someone that's hypermobile in particular, if you're just laying them on their front and pummeling away or loosening it up, it doesn't often work because their body just kind of gets away from where you are. In these positions is exposed, so you can get nicely to do a mobilise in there. You can nicely to get a release here to push down. Obviously the bed would be down more, but you can use your body weight to then mobilise.
That feels nice.
You see? Whereas this one probably moves. Yeah, it does. Yeah, this one.
Yeah, it's
like
like rigid.
Yeah, so you can just do a quick test there, and then you can give them a nice stretch. But again, I'd do it with the bed down so you get more body weight through it. Yeah.
And that would be probably what we're going towards from a point of view of recommendations for follow-up for PIP. It would be manual therapy, because otherwise she's going to keep going doing what she's doing, and she's doing really well, but she does need a little bit of manual therapy. And by changing things here posteriorly all through that thoracolumbar fascia here, will hopefully change again a little bit around where there's that laxity in that midline, and then what's happening here. And then will that allow her, with a little bit of external work, possibly a little bit of internal work over time, in 3 months' time be able to insert her tampon with and it be comfortable. That's what I
Goals.
would hope. Goals, yeah. That's a goal, yeah.
What marathon? Let's just work on it.
While we're in that position, we can do the downward dog or dog face down, however you want to call it. As you did some yoga, you know exactly what I'm on about. So they can start them in this position, come up onto the all fours, tap the toe, that's it, yeah, tap the toes under, lovely. And then we're looking, can she get flat here? So I tell, bend your knees for me, and then push your bum to the ceiling. Push your bum to the ceiling, and push down here more. So straighten your arms, straighten your arms, straighten your arms. So again, it's her thoracic is stiff, yeah. So that's so then that way you've eased off. Now when you try to bring the hamstrings in, probably going to be a bit tight, yeah. But again, we would be checking that core synergy of what, if when she can bring in the breath, etc. there. But this is a nice one. Yeah.
And the other thing is, if you go back up into your down dog, if you had somebody who had a really kind of significant diastasis, lots of laxity here, and it just doesn't, you know, any exercises that they go home with, it wants to look okay, feel okay, and have a purpose. So then when they go into down dog, often it just scoops in here. So the diastasis then draws in, you improve the tension in the midline. So then that's a good exercise, good position to be in, to hang out in. And then you're also strengthening your arms and your legs. And then you can go up and down on your toes a few times, up, and you can feel the increase in her tension there. So the downward dog, if it's comfortable and looks good, is often good from a diastasis, heaviness, dragging in the pelvic area as an exercise from home. And for the correct patient, that would be a nice one for Pip to do. But I think you definitely need a little bit of manual therapy. I would say.
Yeah, an MOT.
And then the last one on that diastasis is like a press up against the wall. So if you hop off and do a press up,
just bring your legs
here.
a bit, come further away from the wall. Yeah.
And again, in that early postnatal, isn't it? You're trying to get the shoulders back over the hips, over the knees. So if they're very anterior tilted, sometimes you can cue that, and you want to again remind them about the breath. So they're going to like breathe in as they go down, and then they're going to.
That's it. You see that engaged then? Yeah.
It's like the diaphragm.
And you want everything to look nice and smooth, isn't it? You don't want any of that like, or you want, because we're regaining, particularly early postnatal, those postural muscles to get the right length, tension, and that coordination, synergy with the breath and movement. That looks pretty
good. She's not dipping there, but you can see that she needed to activate here a bit better. Is it? Yeah.
And then if you wanted to progress that, you could turn to face the window here. Use the bed. So you're going to, again, I obviously now know that Pip has a gym at home, don't I? So I'm like, okay, so then here again, you're going to breathe in as you dip down and breathe out. How's that feel? Is that okay?
Yeah.
So this diastasis, tiny diastasis, is not a problem for us, sure?
No.
It's not. Okay. And rest for me. And come back up into standing. Wriggle yourself out. Does your body, it feels okay? Don't have any kind of tension anywhere that you...
Not that I didn't already.
Okay, for your mummy MOT?
Yeah, I feel normal.
Okay, good. So come lie back on the bed just for a minute there.
My back?
Yeah, on your back. So has anybody got kind of any observations or anything that you would ask so far that we may have missed? Because again, it's the bright lights and everything is sometimes my brain's a bit like... or anything you want to ask Pip, mindful that we're all here for the weekend and everything is... We're all friends, it's all confidential. Now, is there anything from Pip's history to date yet that you've any concerns about or doing really well?
It's just a general observation. I think it comes, and I'm just asking your opinion on this really, I think it comes from the fact that I've worked in an acute setting for so long. I can't get my head around that having asked red flag screening questions. And like that's just because that's so built in my mindset of I must always be screening for urogynae red flags, spinal red flags. And I know it's not, I hope not relevant to hit here, but I was wondering what your thought process is on how you see whether that's not part of our role in this situation. I just interested to know your thoughts on that.
I think we just didn't put that in there because it's just seen as like you've got to pass those ones anyway. You've got to say, you know, any pins, needles, any tingling, any numbness, anything in your saddle area, you know. So then I suppose like yourself, they just roll off the tongue. They would be done straight at the beginning before we even got her on there. Yes.
That's interesting to sort of come from different places to see how people view their roles, and it's how you view your role, and but that is part of our role to be doing that.
I suppose because we're going into depth of like the bladder, you're already getting a lot of that information. So then it's like she would have said, "Well, actually, I don't know when I need to wee." You'd be like, "Oh, hang on a minute,"
you know, part everything else and deal with that sort of thing.
And I can't control my bowels, and you know, so they'd all come in those general questions. So you're kind of ticking them without saying that specific red flag. That's a good question though.
We do have, I was thinking on Clinico, we have a list of red flag questions actually. So I could get those out as well. I don't remember them yet. And then, Pip, are you concerned about your pelvic floor strength? I know you had a, did you say you had a mummy MOT or something earlier?
Yeah, one of your practitioners, but locally to me. When I was about 8 or 10 weeks postpartum, I had a perineal tear. It wasn't a episiotomy, but it was just naturally on one side than the other. She noticed there was a little bit more tension, but nothing crazy, and I didn't have any symptoms of that. So.
And do you, as I said, do you remember which side that was? Whether it was more the right, so it was the left side. Okay.
Sorry, left side.
That's okay. And then if you bend up your knee, so often we would do, even at this point, is, and you can try this all on yourselves, is, if you find your bony wings there, SISs, and then you bring your fingers in a little bit and down a little bit. And then you relax your jaw, relax your shoulders, and then you just take a nice breath in and out your tummy. And it's like, what do you feel when you do a pelvic floor contraction? So often we can feel that co-contraction as the pelvic floor lifts, what tension builds up in that lower tummy. Sometimes it's too much, and then we know that the obliques are overactive. But you can often feel a little bit of tension, and you can feel already asymmetry. So she's already felt it. So you've got more, what are you feeling as you do a pelvic?
Tightness and tension on the left.
See your fingers
when I
pop up.
pelvic floor.
Yeah.
On the right.
And some people, if they can't feel with one finger, like if they're really, flaccid and lax, I go for 2 fingers and I get them to really press down to feel. Yeah.
And then you also want to turn on to your right side. And bend the knees up. And then again, take a nice breath in. And then breathe out. And then breathe in. And then as you start to breathe out, tighten, squeeze and close around the back passage there for me. And you're going to get a pelvic floor lift and a gentle drawing in of the tummy. All on that nice out breath. Good. Take a breath in. And out. Pop this hand onto this rib cage here. And relax. And again, take a nice breath in. And then as you start to breathe out, perfect. I can see and feel significant amount of lift here, which is good. So this is what I'm saying. You can have see, feel, palpate a lot before you ever actually check internally. And then what we don't want is, I think what Pip really manages well is the strength and the firing of her pelvic floor and her deep tummy muscles. They're all fairly balanced. Whereas sometimes you have, this is so strong and comes in so quick that the pelvic floor can't match that. Whereas even here, so take a nice breath in. And then as you start to breathe out, draw the pelvic floor up, draw the tummy in. So it all feels fairly balanced and at the same time. This is probably a little bit stronger than here. And let go.
Marie, if you've got your left hand on a perineum or by the coccyx or a bit when you're feeling for the pelvic floor activation externally.
So where I've got, are you happy to turn over this way?
Yeah.
Let me see if I can do it this way around. So it's like, so you've got your third finger tracks down here, and then you've got your, actually do them like this. So the base of my hand on the sacrum, and then my third finger, with consent, is going to just rest on that posterior part of the pelvic floor. And then again, you want to just take a few breaths in and out to relax. And then when you're ready, I want you to do 8 just quick squeezes, thinking about closing and lifting the back part here. So squeeze, let go, 1, 2, 3, so I can feel that lift. I know that she's doing it correctly. She's not bearing down. There is some movement. I don't know how strong it is. She's not really reporting any posterior pelvic floor. And then what I want you to do is take a nice breath in. And then on the out breath, draw the pelvic floor up. And I can feel that lift. So yeah, sacrum, third finger, yeah? And rest and turn back onto your back. So I would say Pip would benefit from some manual therapy, isn't it? And then pelvic floor internal assessment to see what we find internally.
So just going back to your synergy, because you did the core synergy in this position, then you did it in the sideline, but just to see also whether it bulges, if there's one side of the abdomen that comes in but not the other.
Yeah.
Because I had that, didn't I? When I came to see you at 6 weeks.
Yeah.
Yeah. I thought I was doing great. I'm like, yeah, and she said, oh no, diastasis and this side's not activating. Oh dear, you know. But until you actually, and it's nice because the mum can look down and see their belly's not lifting. So then that was homework for me.
Yeah.
Lying on my side doing that. Yeah.
With the pelvic floor, say, it's good, as I said, to have these models as well. And, you know, when you've done a pelvic floor assessment, often it's nice to be able to explain to the mum what you found. And, you know, they can feel what you feel sometimes if it's very tight or tender. So you can say, oh, well, the tender point was here at the back on that right side. Any thoughts on what we might find with PIPs?
Possibly some left side. On the internally.
Yeah, it does sound like that it would be.
Yeah.
But this is already a little bit tight and overactive, and that's why that's coming in quicker. You might find that it's tight and overactive anteriorly here, but then on the right side it might be tight at the back. But I would imagine, and that's where we have the history, isn't it, MSK-wise, of the arthroscopy. That's what we've seen with some functional tests today, and that's where the tear and repair was. Yeah. Okay, I think that's it for the moment. Yeah.
Yeah, the pelvic floor bit we'll do
Yeah,
all together in the workshop bit. Yeah.
Yeah. Okay, thank you.
Thank you.
Have you any questions?
No, I don't think so. It's really useful.
Any questions on that so far? Is that okay for the moment? Yeah. So I wouldn't stop Pip running. I would just
I was really sensible. So.
yeah.
Only
And again, it's difficult, isn't it? Because she's not having symptoms. Is she going to come back and have manual therapy or not? I'm not too sure. You know, that's again, you're going to have to judge with your patients. It's not like it's, you know, what's the word, urgent, and but it would be good, to do. Or what you can do is you can let the mum know what you found, and then give her home exercises programs to improve the hip mobility, teach her how to massage externally, internally based on what you find as well.